Hello, everyone. Welcome back to Pediatric Question Hub.
Here we learn smarter, retain longer, and feel more confident with every video. Ready to learn hereditary spherocytosis? Card 1. What is hereditary spherocytosis? A common inherited hemolytic anemia caused by an intrinsic defect of the erythrocyte membrane and an intact spleen that selectively retains and removes abnormal red blood cells. Card 2. Genetic inheritance of hereditary spherocytosis. Usually transmitted as an autosomal dominant trait, but as many as 25% of patients have no previous family history, representing either recessive inheritance or de novo gene variants. Card 3. Prevalence of hereditary spherocytosis. It is the most common inherited hemolytic anemia in Northern Europeans, affecting about 1 in 2,000 to 5,000 people. Card 4. Pathophysiology. It is twofold, an intrinsic defect of the erythrocyte membrane and an intact spleen that selectively retains, damages, and removes abnormal hereditary spherocytosis erythrocytes. Card 5. Molecular defects in hereditary spherocytosis. Qualitative or quantitative defects of key membrane proteins, most commonly abnormalities of ankyrin or spectrin, with defects in band 3 and protein 4.2 also contributing. Card 6. Loss of erythrocyte deformability in hereditary spherocytosis. In hereditary spherocytosis, the erythrocyte membrane defect causes the loss of membrane surface area without proportional cell volume loss. Hence, a decreased erythrocyte deformability, leading to trapping and destruction in the spleen. Note: normal red blood cells are usually shaped like a disc, with a depressed center, like a donut without a hole. In hereditary spherocytosis, most red blood cells are circular and shaped like spheres, more rigid and less flexible. Card 7. Mechanism of erythrocyte destruction in hereditary spherocytosis. Defects in membrane proteins cause loss of membrane surface area, leading to decreased erythrocyte deformability, which impairs cell passage through the spleen and results in premature destruction. Card 8. Ankyrin 1ANK1 defects in hereditary spherocytosis. Abnormalities in ankyrin 1ANK1 are the most common molecular defects in hereditary spherocytosis, accounting for 50 to 67% of cases. It is primarily transmitted as an autosomal dominant trait and typically leading to mild to moderate disease severity. Card 9. Clinical classification of hereditary spherocytosis severity. Mild cases 20 to 30% are asymptomatic with well-compensated mild anemia. Moderate or typical cases 60 to 70% have partially compensated hemolytic anemia with reticulocytosis, fatigue, pallor, and intermittent jaundice. Severe cases 3 to 5% have life-threatening anemia and are transfusion-dependent. Card 10. Neonatal manifestations of hereditary spherocytosis. In the neonatal period, hereditary spherocytosis can manifest as anemia and or hyperbilirubinemia severe enough to require phototherapy, transfusion, or exchange transfusions, and is a significant cause of Dat/Coombs negative hemolysis. Card 11. Diagnosis of hereditary spherocytosis. The diagnosis of hereditary spherocytosis HS can be established from a positive family history, presence of typical clinical and laboratory features including splenomegaly, spherocytes on the blood smear, reticulocytosis, increased bilirubin, and an elevated MCHC, usually above 35 grams/dl. If these are present, no additional testing is necessary to confirm the diagnosis clinically. Card 12. Hereditary spherocytosis screening test. An MCHC greater than 35.4 g/dl with an RBCRDW greater than 14% is suggestive. Card 13. Diagnostic tests. If the diagnosis is less certain, additional testing can be performed. These includes EMA binding test flow cytometry, which shows decreased binding of fluorescently labeled eosin 5-malamide. Osmotic fragility test, where spherocytes lies at a lower dilution due to their lower surface area to volume ratio. This is not specific for hereditary spherocytosis. Genetic diagnosis can also be done. Card 14. Hereditary spherocytosis general supportive care. General supportive care includes monitoring neonates for hyperbilirubinemia, anemia, and potential transfusions, annual hematologist visits, growth monitoring, and vaccinations, gallbladder screening, folic acid supplementation for moderate/severe cases, documenting parvovirus B19 susceptibility. Card 15. Folic acid supplementation in hereditary spherocytosis, recommended in cases of moderate and severe hereditary spherocytosis due to the demands of brisk erythropoiesis. Card 16. Indications for splenectomy in hereditary spherocytosis. Partial or full splenectomy is recommended for patients with severe hereditary spherocytosis, moderate HS who experience frequent hypoplastic or aplastic crises, poor growth, or cardiomegaly. It is generally performed after the age of 6 years to reduce the risk of post-splenectomy sepsis. Card 17. Risks and post-splenectomy care for hereditary spherocytosis. Long-term risks includes increased susceptibility to sepsis from encapsulated bacteria, an increased risk for cardiovascular diseases. Post-splenectomy care includes preoperative and postoperative vaccinations, prophylactic antibiotics. Card 18. Common complications or crises in hereditary spherocytosis. Aplastic crises primarily due to parvovirus B19 infection. Hypoplastic crises with other infections. Megaloblastic crises from folate deficiency, which can lead to profound anemia. Card 19. Gallstone formation in hereditary spherocytosis. Bilirubin gallstone formation is common in hereditary spherocytosis patients due to increased red blood cell turnover. Stones can form as early as 4 to 5 years of age and are present in most adults. May require cholecystectomy. Card 20. Rare hereditary spherocytosis complications. Rare complications include splenic sequestration crisis, gout, cardiomyopathy, priapism, leg ulcers, neurologic or muscular abnormalities such as spinocerebellar degeneration. Subscribe and turn on notifications to stay ahead in your pediatric journey.